All right. Hi, everyone. Welcome to the 68th virtual shadowing session. Tonight's session, we have a specialty spotlight in maternal-fetal medicine. All right, next slide. Here's the virtual shadowing working group, and it includes Dr. Fowler, Dr. Salazar, Dr. Marchetti, and Dr. Reno. All right, next slide. And then here are upcoming sessions in September. On September 14th, we have trauma and acute care surgery. On September 21st, we have a session getting into medical school. And then on September 28th, we have a physician scientist patient. All right, next slide. Just a friendly reminder, we will have two Q&A sessions, one in the middle and one at the very end. All right, and Dr. Fowler, do you have some news?
Yeah, just welcome everybody. It's so good to have you. The admissions committee season for medical school is now off and running, as long as is also for PA school, nursing practitioner school. And we're definitely seeing interest by the admissions committees on looking at virtual shadowing hours. I'm pleased to see that. And I think that's good news for a program such as this one, so that the time you spend with us looks like it will get credit. I can't guarantee it, but from my perspective of what I'm seeing, it looks like it will get credit toward your application for medical school, nursing practitioner school, PA school, and so forth. So we're going to keep being here. We are looking for funding to keep picking up the cost. This is about a $10,000 a year program, and we're looking for some internal funding to keep supporting this so we can keep bringing you some really, really interesting people. And we've got, aside from this wonderful talk coming up tonight, we've got some terrific talks coming up in the next couple of months. So please do join us. We'll be talking about critical care and emergency medicine and others. So please do join us. Please keep coming back. And so, Elena, would you introduce our wonderful speaker tonight?
Yes, so I'm sure we are all very excited for this session on maternal-fetal medicine. So I don't want to take up any more time. Dr. Plenty, do you want to take it away?
Sure. So thank you guys so much for having me. I'm Nicole Plenty. I'm a double board certified OBGYN and maternal fetal medicine specialist. I practice in Katy, Texas, which is a suburb of Houston. And you'll hear more about me in this presentation that we're about to go through right now. So I know that when I was contacted, I was told, hey, let's just spend a day in the life of MFM. And so that's what we'll do today. I'll take you through what a typical MFM is. Please stop me if you guys have any questions that I can answer, or if there's anything confusing, please stop, put your questions in the chat. So let's get started. So what is MFM exactly? So maternal fetal medicine is also called perinatology, or at least it used to be called perinatology. It's basically an OBGYN, which is an obstetrician gynecologist who takes care of women's health. So we basically do everything women's health, from deliveries to vaginal deliveries, to bleeding, to GYN or gynecologic issues like menopause. But an MFM handles just the obstetrical side and only the high-risk pregnant population. And so basically, when we look at an MFM, we are obstetrics, meaning we deliver babies. We're radiologists because we do a lot of imaging and ultrasound. We do internal medicine because we're like an internal medicine doctor, but for pregnant women. And we also do a lot of critical care. So we're the people that are managing anyone that's pregnant in the ICU. That will be managed by an MFM in conjunction with other subspecialists to care for a patient that's pregnant. So is this something that you want to do? And I would argue that everybody should want to do MFM. I think it's the best field in the world. You only see pregnant patients. For some people, that's a plus. For some people, they're like, I don't want to just treat pregnant patients. It's a very fast-paced environment. So I can be in clinic and be called for delivery. I can be called for traumas, just like an ER doc is called for traumas. I can be called to the ICU. So you have to think on your feet. It's not as hectic as trauma surgery or ER. In my opinion, it's not. Your ER docs and your trauma surgeons, they're going to be the people in the ER stabilizing patients. MFMs don't do that. So we are consulted. So usually if there's a patient that comes into the ER, they're seen by the ER doc, an OBGYN, and then they're consulted by a maternal fetal medicine specialist once the situation is assessed, or if there's any confusion about a diagnosis, or if the patient needs critical care attention, then an MFM doctor is consulted. So it's not, to me, as hectic as being in an actual trauma center and being in the ER at all times. We do treat a wide range of diagnoses in pregnancy. So anything from a patient that has the flu in pregnancy to hypertension or diabetes in pregnancy to co-management of cancer, strokes, and heart attacks in pregnancy. So we basically do pretty much all the subspecialties, but for pregnant women. We do deliver babies. Some maternal fetal medicine doctors choose to do consultation only and not deliver babies. We do evaluate reasons for miscarriages. And of course, we deal with maternal ICU cases. And sometimes we deal with maternal deaths and fetal deaths. And so you have a really high impact on that high risk population to try to help them get safely through their pregnancies. So the benefits of MFM. So the benefits are so long, I couldn't even write them all down. But for what I could get on this one slide, these are the benefits of MFM. So you get to be with patients on the most important day of their lives. And that benefit is also to general OBGYNs because you're delivering the baby. You're the first person that baby sees when they are welcome to the world, which is an amazing feeling to help a mom finally get to see their baby and to be with that family on that most joyous day. That's why when some MFMs don't do deliveries, I'm like, how can you give that up? Because it's such a great experience to deliver a baby. But you do have the flexibility of not doing that if you didn't want to do that as an MFM. You help high risk moms get through pregnancy. So even when I'm dealing with a mom that has a difficult diagnosis, so their OBGYN has found a breast lump in the breast, and they get sent for diagnosis and a biopsy of that lump, and it comes back cancerous, then they're sent to me so that I can coordinate things with their hematologist and their oncologist, their radiation therapist, to make sure that they have the appropriate dosing that doesn't harm the baby, and they're on regimens that don't cause fetal malformation and anomalies in babies. And so usually that's a low point. And I mean, I've cried with patients, but it's also very rewarding when you get them safely through that pregnancy, and they're so thankful that you were there with them to support them and to make sure everything went okay. And so you are helping extremely high risk moms get through pregnancy, which is very rewarding. You do get to do procedures, quite a few. We do a lot of ultrasounds. We do a lot of ultrasound guided stuff. So anything that can happen in an adult can also happen in a fetus. So if there's fluid on the lungs, we put a chest tube in, and we put that in while the baby is still inside of the uterus. And so you're doing a lot of ultrasound guided shunts. We deal with a lot of bladder obstruction. So the baby has issues congenitally with urination. We would put a bladder shunt there to evacuate urine through that shunt and into the amniotic fluid surrounding the baby while the baby's still inside of the uterus. We do chorionic villus sampling, is what CVS stands for. That's just a really long name for a biopsy of the placenta, basically. And we do those if we suspect that there are congenital malformations when we do a first trimester ultrasound to look at the thickness on the back of the baby's neck. That thickness on the back of the baby's neck is a really important clue that the baby could have a major heart defect, or 50% of the time could have a major chromosomal abnormality. So we do the CVS or the biopsy to then send that off for the baby's genetic makeup, so that the mom can figure out, how they want to proceed with the pregnancy. And also so we can do some further evaluation to see if the parents need to do genetic testing as well. We do DNCs, which is a dilation and curettage, as well as dilation and evacuation. That's after a mom has had a miscarriage, to remove the inside content of the uterus. That is a procedure that surgically removes the inside contents of the uterus. We do C-sections for deliveries. And of course, we do vaginal deliveries as well. And we can do cesarean hysterectomies. That's when moms may have abnormalities of the placenta, where the placenta invades all the way through the layers of the uterus and can attach to the bladder or bowel or nerves and other things surrounding the uterus. And so it would be dangerous to deliver the placenta, which is also the afterbirth at the time of C-section. It would also be.
So Nicole, you actually put tubes through the mother's abdomen into the fetus in the womb.
Yes.
In the setting of such things, you mentioned fluid on the lung and so forth.
Yes.
So you will actually rescue the fetus that has yet to be delivered from all various medical conditions. What an amazing story.
Yeah, it is very rewarding when you put a shunt in and then the next week you see, oh my God, it's working, right? Like you've actually drained the fluid. Sometimes the babies will snatch those shunts off. We try to put them on the side of the baby so that the baby is less likely to pull the shunt off. And of course, babies don't intentionally just grab shunts and pull them. Although we think they do when we put the shunts in, we're like, is this baby grabbing the shunt? But
so Nicole, I guess ultrasound has become an invaluable part of your work, I guess.
We can't function without ultrasound. So 80% of what I do deals with either me doing an ultrasound guided procedure, or following patients with ultrasound. So if their baby is smaller babies have an increased risk of stillbirth. We can look at flow through the umbilical cord to see if the baby is at risk for dying or not. And so we use ultrasound like you put your shoes on every day. We use ultrasound every single day.
How did you develop your skill set for ultrasound? Was that part of your residency training or fellowship?
It was not a part of my residency training. So in residency, I feel like you get a lot of hands-on with the maternal side of things, but not necessarily the fetal side. So in residency, for the most part, and this is a blanket statement, you learn how to do a basic ultrasound in residency, meaning you can measure the baby and weigh the baby. You can assess the fluid. You can tell where the placenta is. You can assess the cervix, and some anatomy you can look at very basically, but you're not taught detailed anatomy, how to diagnose genetic syndromes, how to diagnose malformations until fellowship. And that's why it's a 3-year fellowship. It's not, it's not a short fellowship. It's very long and in the realm of fellowships. So yeah, we have to do a lot of hands-on ultrasound all 3 years.
So Nicole, what prepared you to give difficult news? Let's say that you had what is it called? I'm sorry, I'm old. What is it called when you've got an infant that actually is a cancer in the uterus? It's the
so if I had a choriocarcinoma or an angiosarcoma, or melanoma can cross the placenta. If mom has melanoma, that can cross the placenta and invade and affect the baby actually. So if I have those type of diagnoses and I see it, the first thing I'm going to do is watch it, right? Because usually placental abnormalities are not cancer, but if it's starting to get bigger, globular, disorganized looking, angry looking, and then there's certain characteristics that we look at that say, this is definitely cancer. And then we do some diagnostic workup on the maternal blood, and that can confirm that cancer diagnosis. So I have learned to be very direct with patients. I feel like patients appreciate me more when I sit down and say, listen, I'm really sorry to have to give you this news, but let me show you what I'm seeing. And I usually walk patients through so they can see what I'm seeing and why I'm concerned, so that I'm not just telling them something and they're like in denial. I'm like, this is what's going on and this is why I think this is happening. And then I give them the best case scenario and the worst case scenario. And I've learned to be very objective when it comes to that pause and wait for questions. I think as physicians, we have got to make sure that patients don't leave the office with questions. And usually if I'm giving really bad news, especially that could affect the prognosis of a baby, I'm going to call that mom the next day just to check in and say, I just want to make sure you didn't have any questions about what we discussed yesterday. Because a lot of times when you tell somebody something bad, they sort of they hear you, but they shut down and they forget all of the details. And then it's like, okay, wait, what did you say about this? Or they only hear the very worst case scenario and they forget about the most likely scenario and the best case scenario. They go straight to the worst. So I am very direct. I try to allow patients to ask questions, and I try to foresee what questions they could possibly have and then address them at that time. But residency really prepared me for that, for delivering bad news.
The word I was struggling with a while ago was molar pregnancies, where you
molar.
have this.
Yeah. Molar pregnancy is to me, that's a better, it's an easier thing to deliver because it's not like there was ever going to be a baby. Okay. So molar pregnancies won't ever be real live babies. They can't, they're just basically a doubling of your chromosome number. So you have a molar pregnancy. So it looks like a snowstorm appearance in the uterus. So it's not an organized baby. But if you have an incomplete mole, there are case studies that show that they can go on and deliver, but they usually don't survive after delivery. That's a harder decision. That's a harder conversation when you see a baby and it's an incomplete molar. Yeah.
Nicole, later in the talk, I would love it if you would kind of address whatever you feel comfortable with talking about the new Texas law regarding abortion.
Oh, we can talk about that until I'm blue in the face. I'm very comfortable talking about that.
What an odd time. I've been practicing in Texas 21 years, and it's a strange time. And well, I don't want to get you off track. Please keep going, and we will keep. We will. We've got so many questions already just pouring in, and we're looking forward to hearing you talk. Please go.
So, so those are some of the procedures that we just named before that MFMs get to do. And in addition, I have to make sure I add, and I'll talk to you guys about my journey, but after MFM, there are a subgroup of us that do another 1 to 2 year fellowship on just fetal surgery. And those people do a lot of multiple surgeries. So babies that have twin-to-twin transfusion syndrome, that are twins where they share placenta, where one baby steals more blood than the other, or babies that are born with trap sequence where one baby may be missing a brain and the other baby is the pump baby, meaning that baby is controlling everything in the flow to the other baby. So they do laser ablations where basically they go in and separate the shared blood flow between the two babies within the placenta. And so that's called a laser coagular ablation surgery. So MFMs do that as well, but most of them need some subspecialty training on top of MFM to do that. Rarely, some people feel comfortable straight out of fellowship doing that if they do enough of them, but usually if you're not working at a particular fetal center, you're not doing enough of them to do them after you finish, even if you go into academic practice.
So Nicole, what happened to you? I mean, why didn't you just go into an OB/GYN practice and just deliver babies and take care of moms? What made you take this step further?
Well, Dr. Fowler, I think that may be my next slide as to my why. So if you don't mind, I'll save that answer until I get to that slide.
Please, please.
Because I really tried hard not to do OB, and I'll share that with you guys in a second. I did try hard not to do it.
Okay, let's go.
All right. And so, of course, other benefits is the call is much lighter than the typical OB/GYN call. So like right now, I'm on call, but I'm on call from home. My colleague, I have a friend that is in my group that knows I'm giving this lecture. And so I said, hey, can you cover any phone calls I have between these hours? And so usually, because I'm the subspecialist, I'm not in-house. There's an OB/GYN that's in-house delivering babies. I'm only called whenever there's complications that need to be addressed urgently, or when a patient is in the ICU or when there's an OB trauma. So I can do my call from home. We're considered the go-to experts in pregnancy. So if the OB has a question or a family medicine doctor has a question, they will ask us. And so it's very stimulating because you always have to think, because you get to see the rare, cool zebra stuff in pregnancy. So the downfalls, it can be very stressful because you are the person that's giving all the bad news. The OBs aren't giving the bad news. They're sending them to you because you give all the bad news. It can be emotionally taxing as well, because if you have a maternal death or you have fetal death, it can be quite emotionally overwhelming, especially if you have to give several bad news all day. There was one day that I told 6 people in a row that they had a baby with a major anomaly. 6 in a row. And that was a really hard day for me because you have patient after patient that's coming in crying or they're overwhelmed. And so it can be emotionally tolling. Sometimes you have babies that die. Sometimes you know the baby's going to die before they actually die, and you have to tell the parents that the baby's going to die. Sometimes the moms die. Sometimes both die. So that's the downfall. And instead of call, once every couple of weeks or once a week, my call is 7 days straight. And that's pretty typical of MFMs across the country at the various places I've been to.
Wait a minute. You take calls 7 days in a row?
Correct. But Dr. Fowler, we're taking it from home. We're taking it from home. But yes, you're right. I can be woken up at 2, 3 in the morning or have to go back to the hospital for 7 days straight. That's very rare that I would go in the hospital. That's why MFMs do calls 7 days in a row straight from home. Yep. So how did I get here? So I did undergrad at Xavier University of Louisiana, which is in New Orleans. That was 4 years of undergrad. Of course, you guys know that. I then went to Tulane School of Medicine, and that's 4 years of medical school. During that 4 years, like I was telling Dr. Fowler earlier, Hurricane Katrina happened the first year. And so I should have squeezed Baylor in there, at least had them their small seal there, because for a year we were Tulane at Baylor. That's also when I decided to go back and get my Master's of Public Health with the concentrations in Health Systems Management and Policy, also from Tulane's School of Public Health and Tropical Medicine. And so I merged into the dual degree program at that year of Hurricane Katrina. So that would have been January of my first year of medical school. And then after that, I had 4 years of OBGYN residency at the University of Mississippi Medical Center. Yes, that's Ole Miss. And my sister went to LSU and she was like, I cannot believe that you're going to Ole Miss for residency. But yes, I did, and had great training.
Well, Nicole, I went to the University of Georgia, so I forgive you for Ole Miss.
Okay, well, listen, the reason I went to Mississippi, right? Because I met the program director at the American College of OBGYNs conference when I was in medical school. And at the time, the national ACOG president was Dr. James Martin, who's like a preeclampsia guru. And I had been studying him because like you'll see my why. I had a family member that had some complications in pregnancy, and I wanted to meet this man, and he was so nice. And I was like, I want to go there. And so I applied and ended up getting in and went. But Mississippi is very unique. Being in Texas, there's all these medical schools in the state. And so you have all these people at all these different hospitals. At UMC, that's the only program in the whole state. And so you get all the pathology. If you want to see late diagnosis of breast cancer with a fungating mass in pregnancy, you see it. If you want to see stage 3 cervical cancer with nasty discharge in pregnancy, you'll see it. And you want to do C-hisses on that, you'll do it. So the good thing about Mississippi is I got a really good training. I got a lot of experience because it was the only learning institution in the entire state. And the whole state is high risk. It's number one for everything in healthcare that's sort of kind of bad because people don't have access.
Yeah, well, Nicole, you said something else, and you said it was about the people that you trained with, that you really liked the people, and that you felt a strong connection. And for the now 250 students that are listening, is that the learning period of medicine is about the people that you meet and that you get to know, that take you under their wing, and that offer you the opportunity to learn. And so it is about building personal experiences, don't you think, Nicole?
Oh yeah, I definitely think that. I mean, there are people, I've been out of fellowship now 6 years, and I still call on my program director, and I mean, they get me involved in so much stuff and still write letters of recommendation for me. And when there's a book chapter that's available, they want me on it. If there's a research presentation, they want me to do it. If there are research opportunities that are multi-center, they're calling me saying, hey, do you want this opportunity? So, and when there's funding opportunities, they let me know about it too. So yeah, it's definitely about who's going to take you under your wing, where you feel comfortable, where you fit in at, and where you're going to get a lot of exposure and a lot of experience. And I'm blessed to have gotten that at all of my institutions, honestly. But especially at UMC during my residency and fellowship. And then you have 3 years of fellowship. Now, I know that you guys have probably heard from a lot of different specialists. If they did fellowship like cardiology is another 2 years. A lot of internal medicine subspecialties, their fellowships are like 1 to 2 years afterwards. Even some of the surgery fellowships are 1 to 2 years afterwards. Most of the OB fellowships are 3 extra years. So a total of 7 years of post-medical school training. So it's something that you have to really want to do. But you guys want to do, you want to do medicine. You just have to figure out which field you want to do. And I hope that you want to do MFM, because honestly, hands down, it is the honestly best field. And I'll get into that in a second, but I really do think that it's the best field that I get in. Every morning I wake up, I'm really happy to go work. I can't say that about a lot of people, but I genuinely love what I do. And I think my coworkers also like what they do, so they don't mind coming to work late, going to work at 2 a.m. if they need to do that. You have to love what you do if you roll out of bed to do it. Okay, so make sure you pick a field that
Nicole,
you like to do.
Nicole, do you sit on the bed and hold the hands of your patients and talk to them? I mean,
yes, I do.
Were you that way when you were younger, or is that something that became an acquired thing? It was acquired for me. I've been in practice 44 years, and I realized I grew into the fact that I began to get close to my patients and to really enjoy their company. And was that something that was always that way for you, or did you grow into that?
I think honestly, I probably always liked people. In a sense that I've always felt, my mom called me a fixer. Like if I hear somebody's problem, I want to fix it. So you can't fix everybody's problem, but I've always wanted to listen. I've always been a person to sit and talk to people and not rush people. I don't rush people even now. I don't rush people in my office. If they have questions, I sit and answer them. If I give them bad news and I know I'm running behind in clinic because I can also be very impatient, I will allow them to take a minute, talk to their spouse, step out, see a couple of patients and come back to them, as to not rush them. I think for some people it is acquired, which is good. When I trained when I was in training, I saw people from their intern year be very, very insensitive to, by the end, them crying with patients and buying them popsicles for, cancer patients, their favorite popsicles. So I have seen people transform into being like very textbook, like, oh, this is a case, into really realizing that this is not just a case, it's a patient. This is somebody's child. This is somebody's wife. This is somebody after they leave our clinic. So I think it could be both.
Yeah, over the last year and a half, we tried to present the image here, the fact that physician and humanity go hand in hand, mm-hmm. and that the opportunity to be with someone during a time that they're terrified and God knows what's going to happen, and that you can, number one, scientifically make sense of it, excuse me, and then number two, be able to present them a path to wellness if it can be achieved. And it's so important. Please go ahead. I'm interrupting you.
No, you're fine. You are fine. This is terrific.
We've already got 24 questions and people that got all kinds of questions for you. Please keep going.
So like Dr. Fowler asked, why did you do MFM? Like, why not just do OB or do something else and stop? Well, when I was in college, my first year of college, actually, I had a cousin named Kenyetta. This is her. She was 23 years old. She had her second pregnancy. She had no medical problems. First pregnancy was uneventful, but she went to the hospital. She had a headache. They sent her home. No one recognized that she had mild range blood pressures because it was only a little bit mild. And 2 days later, she went back because she was in pain and she had another headache. And they sent her home again. And she ended up having a seizure at home. And she was brought back to the hospital via EMS. They then transferred her from my small 10,000 person hometown to Baton Rouge, Louisiana, where they diagnosed her with preeclampsia or eclampsia, which is when you have a seizure in pregnancy. Preeclampsia is high blood pressure and vascular damage, which we look for as protein in your urine. Eclampsia is when you have a seizure. So pre is before, and then eclampsia. She then developed HELLP syndrome, which is hemolysis, or where your red blood cells lyse or pop open, elevated liver enzyme, and low platelet syndrome, which put her at risk for disseminated intravascular coagulopathy, which basically means she consumed all of her clotting factors. So you have to have clotting factors for your blood to clot to stop you from bleeding to death. When you have DIC, you don't have those factors, so you just bleed. She then died a month later, and she had to be delivered via C-section at 28 weeks. So once that happened, there were a lot of questions, right? Like, how does somebody that's 23 years old, that is healthy, thin, play volleyball, works out all the time, educated, like, how does this person die in pregnancy? And no one really had answers. And the interesting thing was, being in Louisiana, I interviewed at places that she was treated, and sharing my personal statement, I had people that said, "Oh yeah, I remember your case. I remember your cousin." And this is sort of what happened off record. And that's when I learned that she had preeclampsia and had HELLP syndrome and had DIC. And at that time, the people that had treated her then were no longer at the hospital that she passed away at. They were at Ochsner and at LSU and at Tulane, because they had done other things in their careers and transitioned. So it was good to know what had happened. But that sparked my curiosity in college. Like, why does this happen? Like, what is this? And
Nicole, if I can interrupt, just only to say that
absolutely,
you're really presenting three levels of how your cousin became ill, in that she became hypertensive, and then she presented to a facility where she was found to have hemolysis, elevated liver enzymes, and low platelets, which could have been picked up and her life could have been spared. And then sadly, unfortunately, she got worse. This all due to pregnancy, and then she lost her life.
Yep.
And so this is the heart of what you're doing here with your work, is to try to identify folks, among others, many others, who have this sort of thing that you can intervene with. What could have been done to stop her demise?
It's interesting that you say that, Dr. Fowler, because hindsight is 2020, right? Even when we do Q&A, and I'm pretty sure you probably sit on some Q&As for hospitals, and I've done maternal morbidity and mortality committees for the state of Indiana. And when you go back and you look at cases, it's always like, why isn't this done? And so I don't want to blame the physicians treating her, because they were dealing with the information that they had and the resources they had. But it does put into play, there's a systemic problem here, because one, people that go into the ER that have mild range hypertension are sent home, right? Like, it's not really that big of a deal if a man that was 23 years old came in with blood pressure that's 140/90. I mean, that's not really a big deal. But when you have somebody in pregnancy that comes in, it is something that needs to spark attention. And in my hometown, which is DeRidder, Louisiana, it's super small. It's right outside of Lake Charles. There's not a lot of OBGYNs. I can name them on my hand, the number of OBGYNs. I know them all. And, those are not people that are in the ER, and ER doctors are great. Like Dr. Fowler, you're great. But when you're in a really small town that's not used to seeing things like preeclampsia and HELLP syndrome, they're treating what they know as bread and butter. And so instead of the first time she presented with the headache, them saying, hey, let us consult an OB to figure out if there's something wrong, they sent her home because it wasn't an emergency. You go to the ER for emergencies. And if you're not having a hypertensive emergency or urgency, then it's not that big of a deal. And then she presented again. So in hindsight, what could have happened is when she presented the first time, OB should have been consulted. She should have been admitted. She should have had a workup for preeclampsia. She should have had labs. She should have had a urine collection to make sure she didn't have over 300 milligrams of protein. She should have been treated with antihypertensives, and she should have been monitored. I mean, that's really what should have happened. But preeclampsia untreated can progress to eclampsia, HELLP syndrome, and everything else. A heart attack can happen, stroke can happen with uncontrolled blood pressures if it's untreated or unrecognized. And so, that's what could have happened. But you have to look at the resources, the place that she was in, and the time. I mean, this was years ago. I mean, I was in college when this happened. So this was a really long time ago. Now, Texas AIM, I'm on the Texas AIM Hypertension and Pregnancy Collaborative. And now we're making all of these bundles, right? Hypertensive bundles that say, if there's a pregnant woman that comes in, they have to have an OB consult. And if there's a pregnant woman that has hypertension, this is what alarms you, not, severe range, mild range. But those protocols weren't in place at that time. I'm glad they are now. But they weren't in place. But this is the reason why anything that deals with hypertension and pregnancy, I try to get involved in. It's the reason why I try to disseminate as much information as I can to patients. The reason I started a podcast, because I wanted to give people like down to earth information that was relatable, so that they knew what questions to ask, so they know the warning signs they need to look for. Because a lot of people don't know. And then I don't know what she said when she went in, could have been like, oh, it's just a little headache, or maybe it wasn't even mentioned the first time. Who knows?
Nicole, on a point about the future of medicine, it is the creation of networks of care that really mark how medicine advances. I co-chair the Mission Lifeline Project, which is our acute coronary syndrome network for North Texas. We deal in how to identify people who are having a threatened or actual heart attack and how to assure the quality of care. You are doing a network for women who have preeclampsia and how to identify them and support them and treat them appropriately. And that's an example of how medicine progresses, is networks of care.
Absolutely. Absolutely. So she is my why. This is the why, because I don't want other families to have to deal with what my family has had to deal with. And so I want to break and talk a little bit about preeclampsia, because 3 to 8% of women develop preeclampsia in their pregnancy, which is hypertension plus proteinuria. That is the definition. Hypertension plus proteinuria is preeclampsia. But
explain proteinuria, please, Nicole, for our pre-med.
Sure. So when we say hypertension, newer guidelines say, okay, 130 over 85, but pregnancy, we still use bread and butter, 140 over 90. So anything that's above a systolic blood pressure of over 140 milligrams mercury or a diastolic blood pressure over 90 is considered hypertension. Either or, it doesn't have to be both of them, either the systolic or the diastolic or both. And then when we say proteinuria, we basically have women collect a 24-hour urine sample. Yep, we give them a bucket. It's like, there's no new school way of doing this. We give them a bucket and they go home with the bucket, and we tell them, hey, put another bucket of ice beside your toilet. And then every time you urinate, you're going to put a little nun's cap, which is a hat that you put in the toilet. You're going to urinate in the cap, and then you're going to pour it into the bucket on the side. I'll tell people, don't put ice in the bucket. Don't put ice in the urine. You're just chilling the whole bucket. Some people choose to put the bucket in the refrigerator. I said, that's your prerogative. We just want to be cool. We tell them not to freeze it because that can degrade the protein. So they need to keep it basically a little cooler than room temperature for it to be a reliable sample. But we want them to have at least a liter of urine collected over 24 hours, and then the protein is measured. They have to have over 300 milligrams of protein for that to be considered significant. Now we can also do a spot protein to creatinine ratio. That ratio has to be greater than 0.3 to be significant. That 0.3 is supposed to be consistent with 300 milligrams of protein. So if we have somebody that comes in the ER with really high blood pressures and we want to know, is this just an exacerbation of hypertension and not preeclampsia, or is this preeclampsia? Then we do that spot protein to creatinine ratio. If it's above 0.3, then we treat it as if it's preeclampsia. We confirm it with a 24-hour urine collection to make sure that's over 300 milligrams of protein, especially if there's somebody that's preterm, like a 25, 26, 27 weeker, before we just outright deliver them for preeclampsia. But
what makes them spill the protein, Nicole?
So it's vascular damage. So there are hormones that are released from the placenta called eicosanoids, and eicosanoids cause spiral artery damage, okay, or endothelial cell damage. And that causes those capillaries to be leaky. It's also leaky at the level of the placenta. So it means that the placenta doesn't embed to the uterine wall the way it should. And so the presentation or the function of the placenta is poor. And as a result, people can develop constriction of vessels outside of the uterus because of these hormones. And that is what causes preeclampsia. One theory, which was obviously my thesis in fellowship, by the way, but there are dozens of theories, and that is not the only cause. That is just my research study and a lot of other people's research study on different little eicosanoids and which ones cause it. But then there are also other factors outside of that. You have people that have pre-existing conditions that cause underlying vascular damage and they don't even know it. And so a small insult such as increased or doubling of fluid or doubling of blood volume in pregnancy, which happens by 6 weeks pregnancy, can further damage vessels that are already damaged when people don't even know it. So that's why people that have high blood pressure or hypertension and diabetes, autoimmune diseases like lupus, that's why they're followed by an MFM specialist, because we know they have a higher risk of preeclampsia, and we know they have a higher risk of other hypertensive disorders of pregnancy, not just preeclampsia, in pregnancy. So they're followed very closely if they have those conditions that put them at risk.
This is terrific. I've interrupted you so much. I'm so sorry.
You're fine. You're fine.
Please, this is terrific. Please keep. I wish you could see all the questions. Please keep going.
So my typical day, I wake up around 6 a.m. Why do you wake up so early? I will wake up at 6 a.m. even if I was off. I just wake up at 6. Okay. A lot of my colleagues don't wake up at 6, but I do. I have conference calls around 7 a.m. If not, I usually round on consults in the hospital. I go to labor and delivery. I go to the ICU in the morning. Usually my first patient is at 8 a.m. and they're not ready for me until 8:30 if they're getting an ultrasound. I do the ultrasound myself, like you see me here, if I'm doing a fetal echo. So if there's a baby that may have an anomaly, I will do the echo on that patient to try to diagnose that anomaly, to figure out what needs to happen to the baby after delivery, also to figure out if it's a lethal anomaly or not. I usually have, if I have a lunch meeting, then I'm usually rounding in the morning. If I don't have a lunch meeting, then I'll intentionally round during lunch and not round in the morning. That doesn't change the time I wake up, but I'm usually rounding in the morning or at lunch. If I have new consults during the day, I do them at lunch or right after work. Occasionally, we do some coordinated deliveries. So meaning we're doing, so if there's a mom that has aortic stenosis, if you will, they need volume to sustain their cardiac function, to sustain their output. In pregnancy, your blood volume doubles. So patients that have aortic stenosis, which is like when the aortic valve doesn't want to open and close like it should, and it is stiff, okay? So that extra volume allows you to get more blood out. But when your blood volume drops after pregnancy, If we don't control the volume, then those patients can code. And so it's very important that we know about aortic stenosis before the pregnancy, and at the beginning of pregnancy, we know what that diameter is of their aorta, that big vessel that pumps blood through the rest of the body, so that we are prepared. And so occasionally we'll get cases like that where we're coordinating that with, we do C-sections in the cardiac hospital. We have a cardiothoracic surgeon on hand just in case the blood pressure drops and they have to crack the patient's chest open and do surgery. We have a internal medicine doctor on standby, which is usually pulmonary critical care trained as well, to make sure that we don't have to put the patient in the ICU really quickly. So we do multidisciplinary conferences between subspecialties in these high-risk patients. And so occasionally I will do those, and I will do the delivery of those patients, so that everybody's on the same page and we know what to do so that this mom can get safely through pregnancy. And
so
then,
Nicole, with that aortic stenosis story, you're talking like a cardiologist. I mean, do you find that your work has required you to look into so many different organ systems and to be prepared?
MFM is like every subspecialty to the adult, but in pregnancy. And so it is like a cardiologist in that sometimes our cardiologists don't understand the changes in pregnancy. And so we have to remind them, hey, that's not normal because she's pregnant. So you do have to know all of the physiologic changes of pregnancy, especially with the heart and the lungs. It's a different ball game in pregnancy. And the cardiologists know that. They will say, listen, you need to come and see this patient because we need to make sure that everybody's on the right page. Same thing with pulmonology. There are a lot of subspecialties of adults that don't feel comfortable treating pregnant patients, which is why maternal-fetal medicine was even created, to be the people and the champions of pregnant women and remind people of all the changes that can happen so that you don't have people giving Lasix to people with aortic stenosis to drop their blood pressure because they can code, right? And they're like, oh, she's cardiac overloaded. And we're like, yeah, we want to keep her wet. And when we say that, we mean we want to keep her volume up and we want to gradually drop her volume, as opposed to her all of a sudden losing 1,000 liters during a C-section. If you lose her heart rate, you won't ever get it back with aortic stenosis. And we know
Nicole, you're sounding almost like a critical care doc, that you're maintaining blood volume. You're going to keep afterload up.
Yeah.
I mean, I thought you were a gynecologist and obstetrician, but you're sounding like a pulmonary critical care doc. And
we do a lot of things in pregnancy. We do a lot of things in pregnancy to make sure. And I'm not trying to say we are those things, because we very much so need those other adult specialists to intervene to make sure that we know what we're doing as well. So it's a team effort.
We had a chat comment said, wow, I had no idea how integrative and cool maternal fetal medicine is. This is great. Please keep going. I'm sorry I interrupted.
No, you're fine. So what happens during the clinic? I know a lot of people are like, oh, you have clinics 8 to 5. That's a long time to have clinic. And you're only rounding every once in a while. What happens in a clinic? Clinic, like I said before, 80% of what I do is diagnostic ultrasounds, right? So we're looking at ultrasound to evaluate growth and wellness. We're looking at the anatomy to diagnose heart defects, brain defects. We look at clues to see if there's any genetic syndromes going on. We do genetic counseling for people that have a known history of a genetic problem, like they may have a family history of someone with Fragile X syndrome, which is the #1 cause of mental retardation. We have people that come in that have a known family history of Huntington's chorea. And so they want to know how they can have a baby without their baby having Huntington's. So we do a lot of guided care and preconception care to optimize patients' outcome. We also manage a lot of comorbidities. So we're managing diabetes and checking finger sticks and looking at finger stick logs. We're treating and managing autoimmune disorders in pregnancies like lupus, Sjogren's syndrome, which Sjogren's babies have a higher risk of having congenital heart block. We do a whole bunch of hypertension in pregnancy, whether that's pre-existing or whether that's gestational hypertension. We also do a lot of procedures such as CVSs. Like I said before, that's like a biopsy of the placenta. as well as genetic amniocentesis, which is when we insert a needle into the uterus and would draw fluid around the baby and send that off for the baby's genetic makeup. And like I said, during clinical hours is when we usually have our multidisciplinary meetings to coordinate care for moms that are sick or babies that may need a procedure. So if a baby has, I don't know, thyroid goiter, which is an enlarged thyroid gland, that enlarged thyroid can cause compression of the baby's airway. So that baby may need to be delivered via exit procedure, meaning we halfway deliver the baby via C-section. ENT, pediatric ENT intubates the baby, and then they deliver the baby the rest of the way to make sure we can get an airway in those babies. So we do a lot of coordinated and guided care for both mom and baby to get them safely through the pregnancy, through the delivery, and through the postpartum course as well.
Nicole, can I ask you a quick question?
Sure.
I am, I'm, excuse me, I'm an old guy in medicine, but I am astonished about how the gut microbiome is being associated with so many things in medicine today. This morning, I was reading in the New England Journal about the association in Klebsiella in the guts of neonates that are preemies and abnormal development of white matter in the brains. Are you thinking, and please forgive the extreme question, but are y'all beginning to think about gut microbiomes at all, the bacteria in the gut at all? Is that something coming into your world now?
Yes, it is coming into our world, but it's usually from a realm of premature babies, right? So they're looking at those babies because there's an association with not only gut microbiome, but that gut microbiome actually causing necrotizing enterocolitis, and that necrotizing enterocolitis being associated with intraventricular hemorrhage or IVF in those neonates. That's a lot of data that's coming from the neonatal side, which is not me, thank God. That's the people that deal with all the babies in the NICU. We get the babies to the NICU and then we're like, here you go, here's the baby. And then we take care of the mom after that. But yes, we have had some data on that.
Yeah, I didn't mean to detour, but it's just interesting about how medicine continues to evolve.
Yeah.
And then any one of our 250 kids listening right now, if you think medicine is not going to change while you're in practice, you're just not ready, because it's going to continue to change greatly. Please go ahead. Please.
Yeah, medicine, the medical knowledge doubles every 5 years. So it's going to change. It's going to change. It's changed even in my short career. I've only been out 6 years and it's changed. I mean, and you have to sort of change with medicine. You have to constantly be willing to learn. Every year we do maintenance and certification for board certification. And that's for OBGYN, even the GYN part, even though I don't practice GYN anymore, and for MFMs. We are constantly updating our knowledge on fetal echo, and artificial intelligence is coming down the line in terms of screening lower risk patients and who actually needs to see MFM and who doesn't, who can we screen out with ultrasound technology in lower risk clinics. So it's fascinating, all the things that are coming down the pike. Absolutely.
Yeah. In my world, for example, the combination of listening to heart sounds with a stethoscope with an EKG, with ultrasound, will become one entity with, as you said, artificial intelligence, or as I call it, assisted intelligence, that really lets us really examine the organ in real time.
Absolutely.
Please continue.
Okay, so if you're interested in MFM, what can you do now as a student? So the first thing you need to do is make good grades, right? You can't really get into medical school without making good grades. You definitely can't get into residency without making sure you are passing all of your medical school classes. So make good grades. I know a lot of people focus in undergrad on doing a lot of shadowing, and I think that's cool, but you can't let your grades fall because you are doing other stuff. You got to do, the grades have to come first. If you're in residency, you got to figure out if you like OBGYN. You really, there's no path to maternal fetal medicine without going through OBGYN. So I had someone I was mentoring that said, if I see another vaginal bleeder, I feel like I'm going to jump out of a window. And I told him, well, MFM is not for you, because I don't deal with a lot of vaginal bleeding outside of pregnancy, but I am still a board certified OBGYN, and I have to deal with a whole bunch of vaginal bleeding and training. So you have got to go through OB before you get into MFM. A lot of other fields, some fields you can sort of work your way around that, right? So if you wanted to do, I don't know, sports medicine, you can go through internal medicine or pediatrics to do sports medicine. MFM is not one of those fields. There's only one track, and that's through OBGYN to get through MFM. Now, fetal surgery.
Let me clarify that. So what you just said was the only way to get to your field is that you've got to go through OB-GYN.
You have to, yes.
We actually had sports medicine speak to us this past week, and he actually was an emergency medicine doc.
Yeah,
That's in our institution, and he did EM and then sports medicine. But you're saying the only way to get to do what you do is an OB-GYN residency.
Correct. There's no other track to MFM. And I know there's a lot of other fields that you can sort of, go this, alternative routes. Even if you, want to be an orthopedic surgeon and you didn't match into the 5-year program, you could do general surgery and then do that fellowship. It's not like that with OB. You have to go through OBGYN and then MFM. The next thing you could do is get yourself a Dr. Fowler, get yourself a mentor. If you know that you want to be in a certain field, even if it's not that field, get yourself a mentor that's in medicine that can sort of guide you and you can talk to about, hey, I like this, but I didn't like this, or I'm struggling with this. I need help with this. I'm not making good grades here. Do you think that this is appropriate? Someone you can bounce your thoughts out, someone that can guide you, and also someone that can connect you to other people, right? Introduce you to other people at different schools, in different residency programs, for different jobs. And I think that everyone should have a mentor. It doesn't matter what stage of your career, you should have a mentor. Like I have a mentor. My mentor just didn't go away after I finished training. I still have that mentor, and my mentor still has a mentor. Okay. So get yourself a mentor, and you'll have different mentors at different stages of your career. You may keep the same mentor, and you can have several different mentors. That's okay to have more than one, but get yourself somebody you can consider a guidance for you. And then shadow physicians in the field, whether you guys are doing it virtually like you are now because COVID has shut everything down, or whether you're doing that in person, try to gain exposure to different fields so you know for sure that's what you want to do. If you're an undergrad and you are waiting, you can consider a post-baccalaureate degree program. You consider a master's degree to boost your application. And if you're in a medical school residency, do research on women's health. I mean, women's health in general is a great exposure to MFM physicians, and to OBGYNs. So I think that we will pause for a second and see if anybody has any questions. If you do, you can drop them in the chat.
We have so many questions. Elena, you want to take it away?
Yes, we have a lot. One question we have is, we do have a lot of PA students watching this as well. So sure. One of the questions is there a role for PAs within the specialty of MFM?
Oh my God. Yes. So yes, there's definitely a role for PAs as well as nurse practitioners. I work with both. Usually the physician assistants, I mean, they're amazing. They're the people that I call and say, hey, we got to see his scheduled. And they're involved in the same things that I'm involved in. So they're involved in our multidisciplinary meetings. They're a part of the team. They're in surgery with me right across the table from me, helping me pull these babies out. They're usually reminding me, hey, don't forget this lady, is allergic to X, Y, and Z, or don't forget that's the lady with the aortic stenosis, and this one has mitral valve prolapse. Don't mix them up. So yeah, there's definitely a role for PAs. They are a part of the high-risk team. Our nurse practitioners usually do all the diabetic management for us, as well as like following people with hypertension and making sure patients are following their care plan. They also help coordinate our multidisciplinary meetings. Our nurse practitioners do. Our PAs are usually sitting down at the table as a part of the team because they're going to be in the OR. That's the difference between PAs and nurse practitioners from an MFM standpoint. Our nurse practitioners are not in the OR. They're not helping us with C-sections. They're not helping us with procedures. In a sense, they are, because they're doing amniocentesis and things with us in the office. Our PAs are doing more of the procedures. And if it's an OR procedure, like a cerclage, which I didn't even mention earlier, a cerclage, when somebody's cervix prematurely comes open and people are at risk for extremely early preterm deliveries, we may have to stitch the cervix back closed. Our PAs are assisting us with those. And they also do a lot of post-op care, as opposed to our nurse practitioners doing a lot of diabetic and prenatal care.
Okay, so you're saying that nurse practitioners, they cannot do a specialty in MFM?
No, so nurse practitioners don't necessarily, there are people that do women's health as a nurse practitioners. We have nurse practitioners in MFM clinic. Absolutely. What I'm saying, Elena, is that our nurse practitioners are not in the OR. Okay. They're not in the operating room. They're in the clinic. Our PAs are in the operating room. From an MFM standpoint, that's the difference for us.
Okay.
So as a result, our nurse practitioners are doing a lot of the prenatal care and helping us manage complications on a maternal side. Our PAs are doing a lot of post-op care. Does that make sense?
Yes, that does.
Yes.
And that's great news for all the PA students.
Oh, absolutely.
Oh, yeah.
And so Nicole, let me barge in. What has COVID done to you in your practice? For example, vaccination on pregnant mothers and so on. What kind of difficult decision-making have you had?
Well, Dr. Fowler, we do have a case on COVID in this presentation. And I will say,
wait, that's fine, but go ahead.
It's made things a lot harder because, people were being referred to us because they had COVID, and initially we didn't know what to say. We didn't know what to do. We were experimenting and we were calling up all of our colleagues saying, what are you guys doing? Is there a study that's going on? I have this limited data from China. I have this limited data from Greece. And so we were trying to go by international studies and honestly making up stuff as we went and trying to guide our OB colleagues into the best way to manage patients. And a lot of the drugs that we were doing were very experimental. And we were, sort of like trial and error, like, oh, we're going to give them a Zithro. Okay, that didn't work. Okay, we're going to try prednisone. Well, that's not working. I mean, so a lot of it was very much trial and error, compounded by the fact that people didn't believe it was actually real. And so then you have a lot of people that are super sick, that are very confused by messaging from wear a mask, not wear a mask. And so a lot of people weren't wearing masks. They didn't understand that they could get sick. People weren't understanding that their kids could get sick. People weren't understanding that their unborn kids can get sick. Their pregnancies could be complicated by COVID. And so it made things very, very challenging. And now it's even more challenging because the numbers are so high that we don't have any beds to put patients in that are pregnant. We are, and I'm sure you see it, we have people in the ICU for days waiting on beds in the ICU. We've been turning patients away, trying to figure out where exactly to send them throughout the state and honestly throughout the US, trying to get them in beds urgently. So it's definitely complicated the situation.
Thank you. That's great. It's tough on our end. I'm a disaster medicine guy, and we're working with what's called crisis standards of care about making decisions about pulling people off ventilators because somebody else needs the ventilator who may have a better chance of survival. It's just a very difficult time.
It is a very difficult task, and it's hard when you have to decide who gets a bed and who doesn't, who gets admitted because they are more likely to survive and who doesn't. I mean, it's bad. It's really bad.
Well, Elena, forgive me. Let me pop in a completely unrelated question just for a second, Nicole. How do you feel about male doctors becoming a maternal and fetal medicine doc?
I mean, they outnumber us right now. I mean, there are more women that are OBGYNs, but there are more men that do subspecialties of OBGYN. And so there's a lot more MFMs that are men. The women are on the rise though, okay, but there's still more men that are in subspecialties of OBGYN. I think they're great. I mean, my male colleagues are great. They're well respected. There are women that only want to see a man. There are women that don't want to see a woman. So no, they're great. I mean, they work hand in hand with us.
The student that asked the question went on to say, but can I really relate to the woman because I will never carry a child myself?
Sure you can. That's just like saying a woman that's a urologist can't relate to a man. Sure you can. You have women that are in your family you can relate to. Absolutely.
That's great. Oh, that's terrific. Please, Elena, please go on.
Yeah, so we have another question that says, what is the role of a MFM in reducing maternal mortality, especially in minority women?
Woo, that's a loaded question. Oh. So the MFMs are at the center, right? Because and this quest to reduce maternal mortality in Black and brown women, because they are the women that are dying, because Black and brown women are 3 to 4 times more likely to die in pregnancy as our Caucasian counterparts. MFMs are in the forefront. And so the push is to get more MFMs trained so that the leveling of care can increase. And so when we say levels of care, 4 being the highest level of maternal or neonatal care, 1 being the lowest level, a level 4 can take care of any mom that has major issues, right? So if a mom needs to be on ECMO, meaning the blood is pumped from your body and there's a machine on the side that acts as your lungs and your heart and then pumps it back inside of you, that is a level 4 trauma center, a level 4 maternal care. We're trying to make sure that MFMs are involved, because you can't have a level 4 hospital without an MFM. And you can't have a level 3 hospital without an MFM either. So yeah, MFM is at the heart of that. We are the people that set the standard there. We are the people that are the enforcers of national guidelines. We are the people that everyone goes to for questions about how to treat moms in pregnancy. And we're honestly the people that review all the cases of maternal deaths in the state. It's like a whole bunch of MFMs. I mean, that's what we do. So as an MFM, every day I try my hardest to do my part in reducing maternal mortality, and whether that's through educating patients, whether that's through serving on committees, whether that's through being involved in the American College of OBGYNs or the Society for Maternal-Fetal Medicine. We as MFMs are trying to do our hardest to reduce that. But a lot of that is going to be us making sure we're educating everyone, from the nursing staff and the nurse practitioners and the PAs and the ER doctors and internal medicine and other subspecialties that will come in contact with our patients, in addition to the OBGYNs, to make sure we're all on the same page in terms of pregnancy being a high-risk condition in general.
So Nicole, let's jump into a difficult question. So let's say that you test a woman and she reveals a genetic abnormality that's severe and decides she wants to have an abortion. What do you do about that? How do you handle that now, and especially now in Texas, and it's beyond 6 weeks? What are you going to do?
Well, Dr. Fowler, honestly, now in the state of Texas, so all of the medical directors actually met today to talk about how to handle this, because the state of Texas now, as of September 1st, has enforced their abortion ban. And that ban says that a woman cannot have a termination of pregnancy if you are at least 6 weeks or above. So termination stops at 6 weeks, less than 6 weeks. If there's a fetal heart rate present, it doesn't leave.
When she will just have barely missed a period.
Barely, yeah. She probably won't even know they're pregnant. Most OBGYNs won't even allow you to make a pregnancy appointment until you're 8 weeks, because at 6 weeks, there's a chance we won't even see anything inside of the uterus. So it's a very complex and daunting situation. Not only that, it doesn't make any exceptions for incest, rape, or anomalies. It doesn't make any exceptions for that. It does make exceptions for severe maternal mortality risk. So if the mom has over a 50% chance of dying, it will make exceptions for that. But there has to be 2 doctors in 2 different specialties that touch and agree and say the mom has greater than a 50% chance of dying for there to be a termination. And unfortunately, sometimes we can say, oh, you have a 25 to 50% chance of dying, but it really depends on how your heart function goes in the 3rd trimester. If that's the case, they can't get a termination. We can't really counsel people on terminations anymore. And in the state of Texas, you can be recorded without your consent. And so if I'm recorded without my consent, and I'm talking about terminations, then I can be, I can be held liable. I can lose my medical license and I can be fined or jailed. So it's daunting. The only thing we can do is tell people to research their options at this point. And hopefully they're smart enough to research outside of the state and they understand. We would tell them, hey, in the state of Texas, we can't inform you of all your options at this point. But you have the option of researching alternative options other than the pregnancy is how we have to word it. We can't mention the word termination anymore.
And Nicole, I want to apologize. I fear I might have spoken about a sensitive subject because it's obviously brand new to us and it's very weird. How it's going to play out, we don't know. It's so political as far as the Supreme Court.
It's very political, but it's really not. So it's from a medical legal standpoint, as an MFM, we have got to tell patients all their options if they come in with a lethal malformation, even any birth defect. We have to give them their options of carrying the pregnancy or termination pregnancy. I don't do terminations. I personally don't. I was raised Catholic, but it's my medical legal obligation to tell people their options. And if I don't tell somebody their option and their baby is born with something that can alter life, I can be sued for wrongful birth. Okay. And so then the termination laws come in, and now I can't talk right now. I can't talk about the option of termination because I can be jailed or fined. And not only me, anybody in my clinic that was aware of the discussion, right?
And they can press charges as a $10,000 award or whatever it is, it's crazy.
And so lay patients that may have heard about it in the waiting room can then sue and win $10,000 plus their legal fees.
Well, wait a minute, Dr. Plenty. Are you telling me that you, on the one hand, can't recommend termination of a pregnancy where the kid might be horribly malformed,
yes.
and on the other end, you can get sued for wrongful birth? Exactly. Yes. Where is the relief for this dilemma? I don't see a relief.
I don't know. And it's a really scary point in time for MFMs, because we've really been meeting about this because we don't really know what to do, we're trying to frame this thing in terms of what do we legally say that won't get our medical licenses taken. So it's very, 2 weeks ago, I would have counseled the patient that she has the option to terminate versus carrying the baby to term and doing palliative care and giving her counseling and things like that. But we don't really have that option at this point. We have to put the onus on the patient.
I do have to tell you a funny story. My world is emergency medicine, as you know, and I actually had a partner who was sued for wrongful life because he had a guy with cancer and nobody knew about his DNR. And when he had a cardiac arrest, they resuscitated him and he didn't want to be resuscitated. And so he's sued for wrongful life. Yeah. And you go,
yeah, you can get sued for, wrongful birth is what we get sued for.
Wrongful birth. My goodness. Please keep going. Maybe one more question, Elena, and then we'll let Nicole keep going. Nicole, you doing okay? You need a sip of water, or are you okay?
I'm good. I'm good.
This is a wonderful talk, and we're so grateful. Thank you. Elena, please.
Yes. So the last question I'll say is, so someone wrote, I've read about the mother's addictions being passed on to the fetus. How do you deal with that as a physician?
So it's not like the mother's addiction gets passed on to the fetus. It's that the fetus is having some symptoms of withdrawal. And so as a physician, I usually counsel patients that if they are addicted to something, so let's say the opioid crisis, right? In Indiana, that was really big. Let's say the mom is addicted to opioids. We get them counseling. We ask them if they wanted to be on maintenance therapy, like a methadone maintenance therapy or Subutex maintenance therapy, which is basically a longer acting opiate. Okay, so if somebody's addicted to Percocet or heroin, those are drugs that are going to cause their effects because they bind to mu receptors, right? So mu receptors in the intestines. So we give them, and it causes a high, right? It's a faster acting drug. It's going to cause a high and a euphoric effect. With a longer acting medicine, you don't get the euphoric effect, but you get the binding to the mu opioid receptor, and it just sort of stays there. So as a result, people don't have that high feeling. So we ask them and counsel them and say, let's switch you to a maintenance therapy so we don't have a baby that is going to have some like quick withdrawal after. And usually those babies do rather well if they have a mom that's on maintenance therapy and they don't have signs of neonatal abstinence syndrome or withdrawal after delivery. Some of them do, but the risk is very, very low. We get them counseling. We counsel them and tell them this is the risk to your baby. And these are the things that you need to look for after pregnancy. If there's a mom that's addicted to heroin, we want them to stop heroin, but you have to switch them to something, because we don't want them to have urges and overdose in pregnancy, because that can happen pretty quickly. We don't want them to overdose in pregnancy. So we handle it by counseling the mom on her risk. We put them on maintenance therapy, and then we tell the mom what to look for afterwards. And opioid addiction it's a lifelong journey. And it's not like we don't want to wean patients off of an addiction. We want to put them on something, because if they withdraw in pregnancy, they have a much higher chance of losing the pregnancy. So if they're addicted to Percocet and they don't want to stop it, then we tell them to keep taking their Percocet, okay, until they are in agreement with switching to a maintenance therapy to prevent withdrawal. Okay, so the biggest thing is to not have withdrawal. Cocaine is different. Cocaine, there's no maintenance therapy. So we have to admit them and watch them withdraw and treat them symptomatically during their withdrawal and monitor the baby very closely, and then get them counseling so that they won't be more at risk for using again. That's a much harder addiction to manage in pregnancy, just because there's no alternative there.
Okay, that is very interesting.
It is interesting.
Nicole, do you see that increasing, or is it kind of stable or decreasing?
It actually is decreasing. So the opioid crisis had a wave, and now it's sort of on the downswing of things. Cocaine, I haven't seen a patient with cocaine addiction in a year. I mean, it's decreasing.
There's a lot of meth in Texas.
Yeah, there's a lot of methamphetamine. A lot of methamphetamine, them just because they have really poor dentition.
That's true.
They do. They have really poor dentition.
It's called meth teeth. They do.
Yeah,
they do.
Meth mouth. Yeah.
Nicole, we're an hour and 17 minutes. You can talk as long as you want, but you want to go to your next half now? And,
yes, I think I have cases next.
Oh, this is terrific. Thank you so much.
So our first case that I'll present is a 32-year-old. She's a gravid of 3, meaning she was pregnant 3 times, a pair of 1, meaning she has 1 baby at home. She had no preterm delivery. She had 1 miscarriage, and she has that 1 live baby that she had at term. She had a quad pregnancy that she presented with. That's supposed to say, 21 weeks and 3 days, not 31 weeks and 3 days. She was admitted for rupture of membranes of quad A. She was hospitalized, meaning when we talk about 4 babies in 1 sac, they're quads. There are a lot of different type of quads. And as an MFM, I'm the person that's diagnosing the quads and telling them the different types of quads, meaning are all 4 of those quads coming from different eggs that were fertilized by different sperm, meaning they're really all singletons in 1 sac, or are in 1 uterus, or are 2 of them twins and the other 2 singletons, or are 3 of them triplets and 1 singleton. So I'm the person that's telling the difference between that, because different quads have different risk. Okay. So with this pregnancy, the quad A was a singleton. Okay. So she ruptured the membranes of quad A. Okay. That first baby, that was the lowest baby. And we number them A, B, C, and D. A is closest to the cervix, so it would come out first. So cervix being the opening of the uterus. And then B is the second on top of A, then C, then D is the furthest away from the cervix. So she was hospitalized and started on magnesium. She was given betamethasone for fetal immaturity, which is a shot of steroids that can cross the placenta and help accelerate lung tissue to mature, just in case she delivered early. And she was kept inpatient on bed rest because her water had broken. So quad B then ruptured 2 days later. And so if you can see this, there's no fluid around this baby. So this is the baby. There's no fluid at all around this baby. She was kept on bed rest with the 2 ruptured sacs now. And then quad A delivered the next day, which was 21 weeks and 6 days. And this baby did not survive. So now she's left with 3 other babies inside and 1 quad, which was a singleton and a sac by itself, that delivered. So she was kept on bed rest and she was placed in Trendelenburg. And all that means, y'all, is that She was in the hospital, and we basically tilted her where she was sort of on her head more. So with her feet up. Okay. So it's like a tilt position with the head here and the feet down here. Okay. To try to get all the membranes of the sac to push back into the uterus. An attempt was made to give her more medicines to stop her contractions, but she still delivered basically both of those two babies the next day. And then the next week, she delivered quad D, which is the last baby, at 22 weeks and 6 days. That baby stayed in the ICU for a couple of days and then passed away after that. There has been reports of neonatal survival as early as 22 weeks and 5 days at the institution that I delivered her at. But that chance of survival was only 45%. And when you talk about survival with patients, which I would be doing, which I did with this mom, is when we talk about neurologically intact survival, meaning the baby will hit milestones that normal babies at term meet. That neurologically intact survival is 11%, but that's only based on an end of 3 babies having survived to age 2. Okay. At
Nicole,
6 days.
I thought
Yes,
my
sir.
job was hard. God, good God, what a difficult
It's
situation.
a very difficult situation to
God
be in.
bless them.
And it's like this mom had to lose a baby almost every day, right? Like she went through 4 deaths over the course of 2 weeks of losing her babies. And every time I saw her, she's like, please don't tell me I'm delivering. Tell me you can save my baby. Is my baby big enough to intubate? And unfortunately, only one was, which is this last baby you see. And it just was too small. It just didn't survive. And you can see that the tissue on this baby, the skin is paper thin on these babies. Any little rub flakes skin off. They bleed very, very easily. And so these babies die, not only because we can't ventilate them well because their lungs aren't developed, but because they become hypothermic. They develop infection. Skin is a very important barrier for infection for us. And when you have like parchment paper thin skin like this, these babies have a really high risk of infection. So this baby actually had an infection plus respiratory failure and passed away.
Nicole, how do you go home with that? I mean, really, how do you handle that?
Dr. Fowler, you go home knowing that you did the best that you could. And, this patient in particular had been counseled on a selective reduction, which is where we stop the heartbeats of 2 babies and to reduce the babies from 4 to 2. When we offer people that, which we can't offer them now because of the Texas ban, they would have to go to another state and be counseled further about their options. But last month, we could offer selective reduction of twins. Some people think that we're trying to kill their babies. And I've had a patient that says, you're trying to kill my babies. And I said, no, I'm trying to get you to a point where you can have babies that will go home with you. Because the more babies you have, the more likely you are to have a preterm delivery. So the average gestational age for a singleton to deliver is somewhere around 38 to 39 weeks. That's average. Your due date is 40 weeks. If you have twins, the average gestational age to go into labor is 36 weeks, even though we want to get you to 38 weeks. If you have triplets, the average gestational age to deliver is around 30 weeks, even though we want to get you to 32 to 34 weeks. With quads, the average gestational age to deliver them is 26 weeks. And we know that if you make it, and we know that the likelihood of you having all 4 of them to be neurologically intact is very, very low at 26 weeks, especially with quads being smaller than average singletons. They're dealing with being small and preterm. And so they have a very high likelihood, even at 26 weeks, to act like 24 weekers. And so we have to counsel moms about these options of selectively reducing to twins. So it's a very hard decision conversation to have.
Nicole, with the new Texas law, how do you do a reduction?
Can't do it. So all we can do is tell patients that they have the right to reduce their babies to a pregnancy that would be more likely to make it further. And we encourage them to do research. I had this same issue today. I encouraged that mom to do research. My MA actually called her and told her that we would not be able to talk to her about all of her options before and ask her to research them. And so if a patient asks us about it, then we can say, oh yeah, you have the option to selectively reduce, but we're not allowed to discuss it. And we would encourage you to research it further on your own.
Nicole, I'm so humbled by the difficulty of your job.
Well,
I
we
don't
all
know.
have our own thing, every specialty of medicine has their own thing. And MFM is a very rewarding experience, a very rewarding field, but it can be very tough because we're giving really bad news and really helping people make really complicated decisions through their pregnancy that they may not foresee. Like nobody foresees having quads. Nobody foresees having to lose all 4 of your quads, but we have to counsel people through that. Yeah.
Thank you so much. Please continue.
All right. So case number 2 is a COVID case. So it's a 23-year-old that presented at 29 weeks pregnant due to COVID-19. She initially had mild shortness of breath and a sore throat after going to a cookout at her aunt's house. I can't even count on my hands and my feet or fingers and toes how many people have gotten COVID from like cookouts, their own baby showers, and from people that are family. Okay. It's not that they're going to the movies or that they went to the grocery store. I don't have that a lot. It's like, oh, I had stepkids and those kids went to their mom's house and then came back with COVID. Or, oh, I had a baby shower and somebody at the baby shower had COVID. I mean, there are people that they come in close contact with that are family members or friends that inadvertently are giving these women COVID. And so people think they're careful because they're not really going anywhere, with to remind people that COVID can come to your house. It doesn't just live in the grocery store. People can be walking around asymptomatic. Pregnant women are predisposed to getting severe disease. Why? Because they're immunocompromised. Well, why are they compromised, Dr. Plenty? Because they're carrying a creature. Okay, a pregnancy is a creature. It leaches onto you. It doesn't necessarily have the same blood type as you. It has different genetics than you. And so in order for your body not to fight off your own pregnancy, your immune system has to be reduced. And because your immune system is reduced, if you get the flu, you have people that are sick and hospitalized in the ICU with the flu, and they die from the flu in pregnancy. If you get COVID, you can get a spectrum of people. Some are asymptomatic, some need ECMO. I mean, it's a plethora of scenarios with COVID-19 because patients are immunocompromised. Even people that are incidentally found to be positive for COVID, when they come in for their deliveries, we now screen every person that touches the door that's scheduled for delivery for COVID, even if they're asymptomatic. Why are we screening all these people? Because we know that pregnancy causes you to be immunocompromised. If you have underlying lung disease and you have third spacing and fluid shifts that happen 48 hours after you deliver, your body is trying to rid the fluid that you gained in pregnancy. Okay, you're going back to your pre-pregnant state. Well, if that fluid is going into your lungs and you're not able to clear it because you have underlying lung damage from COVID-19 and you didn't know it, we find that those patients are coding. And so they get really, really sick in the postpartum period. They walked in laughing, and then all of a sudden they're on the floor because they were asymptomatic with COVID-19, and now they have an insult because of third spacing and postpartum changes that happen in every woman that delivers. So COVID has definitely complicated the situation. So if we have a patient that's positive with COVID, we treat them very differently, and we watch them very closely in the postpartum period to make sure they don't all of a sudden have pulmonary edema or where fluid builds up in the lung and require intubation after delivery. So this patient was admitted 3 days later after she was diagnosed with COVID because she developed severe shortness of breath, a cough, and fever. She was intubated 2 days later, and then she was delivered via stat C-section because the baby's heart rate just plummeted. Okay, so you're talking about a mom that has to deliver a 29-week baby due to COVID-19. And you know what patients say as to the reason that they don't get the vaccine? They don't want to harm their babies. I don't know what it'll do to my baby. And as an MFM, I'm constantly reminding people about how the mRNA vaccine works and how the natural antibodies you will build when you get the vaccine can cross the placenta and give the baby some boost to its immune system, because babies don't have immune systems. They don't make their own immune cells for 6 months. They're generating these things. So babies have very poor and brittle immune systems. And so those antibodies can help actually boost the baby and protect the baby from COVID-19 itself. But moms are so afraid right now, and they're receiving so many mixed messages about this vaccine that they don't want to get it. And as a result, you have patients like this one, or like the ICU nurse that made the news last week that was 34 weeks pregnant and had to be delivered and died, leaving behind her 5 kids. She died of COVID-19 in pregnancy, 34 weeks, and her baby's in the NICU. You don't really care about that.
The most interesting thing I've heard in the last couple of days was someone said that they'd heard from a doctor online that when you take the vaccine, you start generating spike proteins all over your body, and then they go to your brain they mess with your brain. And I go, I don't know what to say about that.
The misinformation is real. Like, I don't understand how people are getting their information. I think that as physicians, like, one reason that I started doing social media, a lot of social media stuff during the pandemic, because before the pandemic, I was not really on social media. But the AMA, I'm a leader within the AMA. I'm on the Women's Physician Governing Council, and they really encouraged us to be more vocal, because everybody else that's not doctors are very vocal on social media. Everybody's an expert that's not a doctor on social media. And so they have encouraged doctors to become more vocal on social media to sort of, debunk all these myths that are going around about these vaccines, because people are dying based on information that they're getting from, random blogs or random groups or, random people that are claiming to be experts when they haven't seen an ICU ever. So,
Nicole, it's so true. Tucker Carlson on Fox News, which I don't watch, but a couple of weeks ago, he said, people are dying after the COVID vaccine. 4,200 people have died after taking the COVID vaccine. Well, for every 150,000 people per day, someone dies. Heart attack, stroke, trauma, overdose.
Will die. Everybody is going to die.
That's right. And so the point is, when you have 150 million people who've taken the COVID vaccine, yes, there are going to be several thousand people that have died that has nothing to do with the COVID vaccine.
Yeah.
Nicole, 5.4 billion doses have been given of the COVID vaccine, and it is the safest medication in the history of humanity ever invented. Yeah. And still we have situations like this. I'm sorry, but I
tell people all the time, like, the flu vaccine is recommended in pregnancy. There's definitely more reported side effects of the flu vaccine than the COVID vaccine. And people need to be reminded, you don't know what the vaccine will do to your pregnancy. We don't know all that COVID will do to your pregnancy. We don't know the long-term effects of that. And we know that now people are talking about post-COVID syndrome. These patients develop chronic cough, chronic lung disease, chronic kidney failure, and things like that. So people are unfortunately uneducated and under-researched in this thing. And so it's our job, and you guys' job too, as future clinicians, to make sure that you're giving people evidence-based medicine. And that's everybody in the care team. Everybody needs to be talking the same talk to make sure that patients get evidence-based information. Everything you do and say should be evidence-based. And if you don't know something, you should always tell the patient, I'm honest. I said, I need to do a little bit more research on that, and I'll get back to you with more information. Okay. You don't have to lie to patients. You can tell them that you're going to get back with them.
Yeah, Nicole, in my world of emergency and disaster preparedness, we have a thing called crisis standards of care that I mentioned a while ago, and that theoretically, it may be that we're not even allowed to discuss whether a patient has been vaccinated. And where that's going to go, we sort of really don't know right now. That it may be a thing that, people have the right to choose, and therefore you can't discuss it with them whether or not they've been vaccinated. And because it may affect how you care for the patient. Well, maybe that's true.
It really does affect how we care for the patient, because I know if I have a mom that tested positive for COVID-19 and she's been vaccinated, I feel better. I know that she's not going to need an ICU admission. I know to call and check on her in a couple of days to see how she's going, but I know that she's not going to be somebody that's severely sick and debilitating. And I also know that her baby already has some antibodies that's protective. If I know somebody's not vaccinated, I'm much more serious about that situation. We're going to admit them to the hospital probably earlier than somebody that is vaccinated, because we know they're going to do poorly. They can go from having a mild cough to all of a sudden shortness of breath in 24 hours. So it is a difference of treatment with good reason.
In North Texas, the report today is that 14% of all inpatients of pediatric patients in pediatric hospital, children's hospitals, 14% are now COVIDs. This thing is just terrible, and it's not getting any better.
Well, in Houston at the women's hospital, it is up to 40% of admissions are COVID now. 40% COVID across the whole hospital. It's bad. Yeah. So
Nicole, we've had you for an hour and a half already. You doing okay? You got another case?
I'm doing okay, and I'm actually almost done.
Dr.
Well, no,
I have one more case and I'm almost done.
I have a question.
You can talk all night. You got 230 people listening to you, and we love what you're doing. So just please take it away.
Elena, you have a question?
Yes. So you were talking about the immune response and the immune system. So my question is you said the fetus doesn't have an immune system, so the mom shares her immune system. So if the blood type of the baby, if it gets into the mom's system, does that affect future kids? If it were, because it would produce a response, an immune response, right?
It depends. So if the mom, it really depends on the heterozygote. This can be a complicated answer, Elena, but it really depends. So if the mom is Rh negative, so A negative, B negative, O negative, AB negative, only 15% of the population is something negative, okay? If the baby, meaning is positive, because 85% of the population is positive, and if the dad is positive and the mom is negative, then there's a high chance that the baby will be positive. But there's heterozygous and homozygous zygosity when it comes to blood typing, which is why it can be very complicated, because that's a genetic issue. But just for the simplicity of this conversation, if mom is negative and the baby is positive, and that blood is crossed. So if the mom gets in a car accident, if you will, and has vaginal bleeding at 10 weeks, that's why if that mom goes to the ER and she has vaginal bleeding, we automatically give them RhoGAM, which will prevent the mom from creating antibodies that will then go on and attack the next pregnancy, okay?
Okay.
So she develops antibodies that are against the baby's blood type, and then she gets pregnant again with a baby that is also Rh positive, if you will, A positive, B positive, AB positive, O positive, then those antibodies can attack the future pregnancy, but they don't really impact that pregnancy. What we worry about with blood crossing is a fetal hemorrhage or the baby's blood volume dropping, because the baby's blood volume is actually very low. And so if the baby becomes anemic, they can become very hydropic, or develop fetal hydrops, which is when you have fluid that builds up in two or more compartments. So fluid around the brain, fluid in the brain, fluid in the skin, fluid around the heart, fluid in the belly. If they develop hydrops in two or more of those compartments, that has a really extremely high risk of a stillbirth. And so we'll be watching that baby through the pregnancy to see if that baby needed what's called a PUBS, or percutaneous umbilical blood transfusion, or blood transfusion while the baby's still inside, to treat that hemorrhage or to treat that low blood count, okay? But yes, if that blood is combined, it can attack the future pregnancy.
Okay, that makes sense. Thank you.
And that's called alloimmunization. That would be a cause of hydrops, yes.
Okay.
Okay. All right, so with this particular mom, she, the mom was intubated for 3 weeks and then extubated. The baby is still in the NICU from what I know of right now. She produced breast milk using the breast pump. So people think just because somebody's intubated or in a coma, they can't breastfeed. That's not true. So this mom breastfed even though she was intubated and in a medical coma. And then the mom is now extubated, but she's still in the hospital. But that's COVID. So if you know people that are pregnant, tell them they can still get vaccinated. And then this is our last case. Our last case for today is a 24-year-old who presents at 23 weeks for further evaluation, sent by her OB because there was too much fluid around her baby. This is her second child. Her first pregnancy was uneventful. She had no medical problems that she was aware of. She had no family history genetic issues. So this is not her ultrasound. It's just an example. But this is showing you how hazy everything is. That's because there's so much fluid that it's causing it to be very, very hazy. Okay. And so this patient had amniotic fluid that was similar to mine, which was around 32 centimeters. So the ultrasound, which is hers, revealed fluid around the fetal heart, which is called a pericardial effusion. So if you look at how big, it takes up almost the whole chest, this heart, and this muscle is very thick. Okay, this is a 4-chamber view of the heart. You can't see the valves, so that's why it looks like 2 chambers, but there's really valves there. So this is filling, basically. This is diastole. So this is the filling phase, which is why you can't see the valves because they're open. And then this black area is fluid all the way around the heart. Okay. Let me go back. And that's called a pericardial effusion. Okay. And she also had abdominal ascites, which I guess is redundant, ascites, which is just fluid in the abdomen. Okay. So you can see fluid there on this transverse view. You can see that there's fluid all around here at the level of the liver. That's a hepatic vein curving away. So I know I'm at the level of the liver. That's the stomach bubble. So I can see that there's fluid all the way up, okay, under the liver. And then
this is you doing an ultrasound in the office on this woman who's pregnant, and you're looking at the compartments on the fetus inside the womb. Yes. That's amazing.
Yes. So if you have fluid that builds up in more than 2 compartments, and 2 or more compartments, then that's considered hydrops. Okay. So skin.
Where does it come from? Where's the fluid come from?
So the fluid comes from a backup of the lymphatic process. So it's basically lymphatic fluid and the lymphatic fluid not being able to be cleared. Okay. So usually you're absorbing lymphatic fluid into the bowel and then you're processing and urinating it out. And if you have a blockage there, then that can cause some issues. You can also have heart defects that cause this, like the heart just not pumping well enough can cause fluid to back up and pull into the extremities, just like it would in us. And it can also pull into the lungs. So you can have pericardial effusion and pleural effusions that way as well. Infection also causes an attack of your lymph nodes and the lymphatic system. So that's how it causes ascites from an infectious process as well. And then you have some babies that have a certain type of hemoglobinopathies that cause severe anemia, and the heart can't pump as well because it doesn't have the volume to pump. And so you have a thick globular heart that's not pumping well. Fluid then backs up because of the contractility is poor, which can then lead to fluid buildup in other compartments.
So Nicole, you just run through a differential diagnosis of pericardial effusion in the fetus. That's very interesting. It's multiple causes.
Yes, a lot of multiple causes. Yes. And so her AFI was also elevated. So normal amniotic fluid index, meaning the amount of fluid that's supposed to be around the baby, cushioning the baby, should be around 5 to 25 centimeters. Anything over that is considered too much fluid or polyhydramnios. Anything below 5 centimeters is considered oligohydramnios. So she has polyhydramnios. So all of these findings that she's had, polyhydramnios, the pericardial effusion, the pleural effusion, and then also what looks like some skin lymphedema as well there, is consistent with hydrops fetalis. And so there's a lot of differentials of hydrops fetalis. There they all are. And she was evaluated thoroughly for fetal hydrops. So we did a blood type and screen. We did an ultrasound. We did a fetal echo to look at the heart function to see if there was actually a defect causing this poor functionality. We did genetic testing. If you look at your differential, the highest thing is cardiovascular malformation. Okay, it's going to increase your central venous pressure and cause you to have hydrops just because you have heart failure. That's a third of cases are because of heart defects, which is why we have to do a fetal echo. Chromosomal abnormalities account for about 15% of this because it's related to cardiac malformations, lymphatic malformations, and blood dyscrasis. Infection is a rarer cause, being 5 to 7%. High output cardiac failure because of blood dyscrasis or blood hemoglobinopathies like alpha thalassemia is also a cause. And then you have other things that are rarer. And then you have people that come in and we do a workup and we have no earthly idea why they're hydropic, but we still follow them. We monitor them for signs of fetal anemia. And if they don't have anemia, we want to make sure we get them to at least 34 weeks. Now, hydrops has a really high chance of fetal death, but the issue with hydrops is if you deliver them before 34 weeks, then the chance of survival with hydrops that's unknown cause is 0%. So we have to counsel the moms about these, her risk. We have to monitor them very closely, try to get them further out into the pregnancy to get them to a point where we can deliver them safely and the babies will survive. So this patient's blood type returned A positive, antibody negative. So it wasn't that she had a blood abnormality. Her fetal echo showed diminished cardiac function, but no abnormalities. Her torch panel was positive and the genetic testing was negative. So if you look at torch infections, the majority of your torch infections, which stands for toxoplasmosis, other is the O, rubella is the R, CMV is the C, and H is herpes simplex virus, okay? And when we talk about what causes hydrops from a torch infection, the most common thing is going to be toxoplasmosis, which people can get from changing the kitty litter. So that's why we always ask patients as MFMs, and people are like, why are they asking about the kitty litter? We're asking you about it because toxoplasmosis. Toxoplasmosis is treatable in pregnancy, but it is spiromycin has to come from the CDC. It has to be confirmed in one lab in Palo Alto, California, and then you have to get permission from the CDC to get the treatment. So it's very complicated and expensive to treat. This patient did not have toxo. She had other, okay? She had a torch panel that returned positive for Parvovirus, which dogs carry Parvovirus, okay? An ultrasound was done to evaluate the velocity of flow in the middle cerebral artery. So we look at the flow in the middle cerebral artery of the brain to evaluate fetal anemia. So it's almost like if you have your finger over a hose pipe, instead of the flow, the water just trickling through, if you put your finger over it and decrease the diameter of that hole, blood is going to flow through faster. Same concept with the brain. If you have fetal anemia because of a torch infection, because it's caused lysis of cells, then we're going to have increased velocity of flow in the middle cerebral artery. That's been the artery that's been shown most closely related to correlate to the degree of anemia. So we do that. And then her baby was found to be anemic. We then did a percutaneous fetal umbilical blood sampling, or PUBS, which this is the diagram that shows that if this is the baby here, and this is the umbilical cord, and this is the placenta, what we do is we take the patient to the operating room, we insert a needle into the cord, okay? And we're talking about something that's the diameter of, it's funny because my fellowship director used to measure the diameter of the artery that we were trying to hit, right? And he'd be like, oh, this is 0.3 centimeters that you're trying to hit, right? And so you're doing this under ultrasound guidance to hit that one artery. You don't want to hit a vein because if you clot off the vein, you only have, you're going to clot off of the vein and the baby's going to die. So you're doing this under ultrasound guidance to get to the artery, withdraw blood, and then have your medical student run the blood to the lab to get a CBC. We then all hand calculate how much blood to correct the baby with. And then we call the lab then runs the blood to us. And then the medical student attaches to the needle, which we've held in place for 10 minutes, and squeezes the blood to transfuse the baby, okay? So this was done for this particular patient. And then we do middle cerebral artery 24 hours later. And then we repeat that at 72 hours. And then we repeat it at a week to make sure that the blood count is sustained, okay?
Having gone, having stuck a needle through the placenta, which is known to bleed like hell,
yeah,
to get to the umbilical artery, that's pretty brave.
yeah, it's we do amniocentesis every day though, right? I mean, we're trained to do this. We do them every day. And so it seems nerve-wracking, but it really isn't. I mean, it is, but it isn't. I mean, you just done so much of it that it's sort of kind of natural. So now I'm done with cases.
Tell us about yourself.
Now I'm done with cases. So what can you expect as life outside of MFM? The good thing about MFM is that I chose this because I could impact high-risk pregnant patients. I could be the go-to medical expert for them. And I can also have really good work-life balance. OBGYNs, they have a hard life. They are delivering babies at all times of the night. I don't have to do that. Okay. I'm only dealing with super high-risk pregnancies and super high-risk deliveries. Everyone else I'm doing consultations on. So I have a family. That's my son who's stolen ice cream out of the freezer and is eating it on the floor. I like to bake. I like to cook. I do that often. I'm able to leave work on time so that I can give talks like this to you guys. I'm also in a lot of different organizations. I've been giving a lot of Zoom talks over the past couple of months. And so I'm involved in ACOG, which is the American College of OBGYNs. I'm now the new young physician board of trustee member. I'm on the Society for Maternal-Fetal Medicine's Health Policy and Advocacy Committee. I've done the Texas AIM Hypertension and Pregnancy Collaborative. I have a podcast that I do every week about different complications in pregnancy. I have a YouTube channel that I talk to about quick tips for patients as well as students about different diagnoses. I have a blog that I talk about my everyday journal and interesting things that I've learned along the way. So I have the flexibility to do those things. And after when outside was open, my husband and I used to do a lot of traveling. And so I like the flexibility that MFM gives me. It's a hard job. It can be, you're the person that's always reading articles and always trying to stay up to date with information, but it's very rewarding. And when you're off, you can be off and you can enjoy your life. And so I want people to keep that in mind. I know we talked about a lot of hard things, but it does allow you a lot more flexibility than other fields would allow you to do. And so you have to ask yourself, is MFM really for you? And you need to be realistic with what you want your life to look like. And that's with any field. What do you want your life to look like? Look at the people that mentor you when you're on your rotations. Are they happy? See if they are happy. Ask them, would they go into the field again if they had to choose it over again? Go into each rotation with an open mind. I have a lot of medical students that go in and say, oh, I know I want to do OB. No, you don't. Just go into all fields thinking you want to do that field. And you may be surprised at what you really, really like. I tried my hardest not to like OB. Okay. Although I had a cousin that died from complications of preeclampsia. My mentor told me, do not go into that malpractice rich field. Don't do it. And that was a mentor that I got once I started doing health policy work. And once I got my MPH in health systems management, he said, don't do it. That's a really high malpractice field. And I just loved it so much. I was overjoyed every time I went to the hospital. I just wanted to do it. Like I didn't like anything else more than that. And so go into the field that you like the most. So just keep an open mind when you're going through your rotations.
Yeah, Nicole, the thing I would add to that is, and I counsel students who are doing applications, be careful when you're going into your application period for med school, NP, PA, be careful about having your mind already made up. I want to do this, because that probably seems a little closed-minded.
Yeah.
So I would just urge the students to be cautious about that.
Yeah, be very cautious, because you never know what you're going to like. And then you don't want to like something and then you didn't make a good impression, or because you weren't putting your best foot forward because you didn't think you're going to like it. So just keep an open mind about that. For MFM, you need to figure out if you like procedures. If you don't like blood, if you don't like procedures, if you don't like being in the OR, MFMs that are consultation only don't have to do a lot of OR stuff, but you do have to do OR. And you also have to do OBGYN residency, which is 50% of the time being in the operating room. So you have to figure out if you like procedures and surgery. And if you don't, then MFM is not for you. And then you need to ask.
Can you cannulate an umbilical artery through the placenta?
That's all learned. That's all learned. It seems hard, but everything people do is all learned. Yeah, all learned. Do you want to be more in a hospital or in a clinic? Do you like having in-depth conversations with patients, or do you really not like people? I mean, some people, I have a friend that's a pathologist, and she said, I don't want my patients talking to me. I'd rather not talk to my patients. And that's a real thing. Okay.
Nicole, I heard a joke. What's the difference between an extroverted pathologist and an introverted pathologist? And the answer is the extroverted pathologist looks at your shoes while he's talking to you.
So true, though. You have to be okay with giving the bad news. You're the bad news deliverer with MFM. And you also need to ask yourself, I mean, is family important to you? Because if so, MFM could be a great field for you because you get that work-life balance. And then you have the option to do teaching. You have the option to do research if you wanted to. You can do private or academic practice or a combination of both. So for me, I work for obstetrics, which is a private practice, but I am academically affiliated with University of Houston and Texas A&M and residency programs with UT, as well as St. Joseph's residency program. So you can be academically affiliated and do research as well, even if you're in private practice. So you just have to know what you want your life to look like. But that can be figured out down the line. This first column needs to be figured out while you're going through it. Okay.
I will say, Nicole, that here in my late age, I really like working with residents, the young docs that are coming up. I prefer that. Part of it is that they do most of the work in the ER. I know that's true, but still, I just love the young personalities. We picked them, we chose them, and then they come work with us for years. And you get to know these wonderful kids and watch them grow up,
Right. Well, that's all for my presentation. If anybody needs a mentor, if you just want to know more information, you can email me. I'm pregnancypros@gmail.com. I'm also on social media on Instagram and Facebook. There's my little QR code that you can go to, which will get you to my link tree and the podcast and the YouTube channel and basically everything about me. It will get you there if you need more information or need some guidance. I'm more than willing to help out. So questions. Any questions, Elena? Do we have time for questions? I know I'm running my mouth.
Yeah, we got nothing but time.
Yeah. So we do have a couple more questions.
Sure.
So I'll begin with some. So one is, how often do you see a childbirth through the beginning to delivery? So like, for example, once you do a consult for, let's say, hypertension, does the mom and baby stay with you as a patient until delivery or go back to their OB-GYN?
It depends on if they've been sent for total care or not. So most of the time, if it's somebody that just has like high blood pressure, I may only see them one time for consultation just to give their OB some guidance and say, hey, they need a detailed anatomy scan to make sure everything's good on the baby. And they need a growth scan at 32 weeks. And I lay out a plan for their OB and I may never see them again. But if there's somebody that has hypertension and a history of a stroke or a heart attack, then 9 times out of 10, their OB is going to transfer them for total care. And if they do, I'm seeing them from the beginning of pregnancy through the C-section or vaginal delivery through the 6 weeks postpartum period. And then I'm referring them to internal medicine for further care of their hypertension. So it just depends on the severity and depends on how comfortable the OBGYN is with their diagnosis, if I'm going to be co-managing them, if I'm only going to do a one-time consultation, or if I'm going to see them for the total care.
Okay. And then another question we have is, during a consult, are you allowed to speak about religion and offer some type of spiritual advice, such as prayer or anything that can help the patient?
Yes, I have prayed with numerous patients. On their intake form, they're asked their religious affiliation and whether or not they have a strong religious background or not, and whether or not they would want to have a chaplain available and things like that. So I know that going into a consult. And so if a patient has a difficult diagnosis and I think that they're having issues coping, then I always offer them prayer. That's me. If there's a patient that is not my religion, then I will refer them for counseling and for spiritual guidance with somebody, a counselor that is of their religion. If a person doesn't want religious counsel, I always set them up for counseling in general, whether that's palliative care counseling or whether that's just counseling for mental health wellness in general.
Okay. And then another question we have is, what is your experience with babies that are breech?
So I have done quite a few breech vaginal deliveries by accident. And I say that because we try not to do breech vaginal deliveries anymore, right? Because there's a risk that the cervix can clamp down after the body's delivered and you have head entrapment, which is a surgical emergency. And the baby can die and the mom can bleed out with you trying to get the baby out. But occasionally I have done breech vaginal delivery. My experience mostly is with twins. That's the exception to the rule. If you have twins and the first baby delivered head down, you can deliver the second one breech. And so I've done a lot of breech vaginal deliveries of the second twin. Okay. But singletons, I try not to do them. I have been called by OB-GYNs quite a bit for putting Simpson forceps on breech babies to try to get them out. I would be the person that would be called for that type of expertise.
Okay. And then another question we have is, could you explain spinal or epidural anesthesia extending to the T9 and T10 levels? And is it the best method to prevent dysreflexia?
Yes, an epidural is the best way to reduce your risk of autonomic dysreflexia. And that's if a patient has a spinal cord lesion that's at the level of T6. But the difference between a spinal and epidural are the spaces that they're in. So there's 3 spaces. So a spinal is given in the spinal space. The epidural is given in the epidural space. Spinal in the arachnoid space, and the epidural is in the epidural space. So it's just depending on the level that the medicine is being injected. That's the difference between the two. Also, the length of time that they're given. One only lasts 4 hours and the other is continuous. So that's the difference between those two. Usually, if I'm in a surgery, most of my anesthesiologists are going to place a combined spinal epidural because the case can last much longer. And because of the extent of dissection that I sometimes have to do, if it's a cesarean hysterectomy, patients can have more issues with pain control. I hope that answers your question, but I'm not an anesthesiologist, but that's the understanding. That's all the understanding that I have for epidural. But yes, that is a treatment of autonomic dysreflexia, which is a board question, by the way, not for y'all, but it's like a step 1 board question actually for medical students.
So Elena, I think we'll thank Nicole for her wonderful kindness. We've been going for 2 hours now. Nicole, what a great talk. This is just wonderful. I want to ask everybody still online, all 200 of you, to put "thank you, Dr. Plenty" into the chat so she can see all of you say thank you so much.
Thank you guys for having me. I appreciate it.
For your wonderful kindness. What a terrific talk. This was great. And it was so informative for me. You know, we do an EMS fellowship, which is ACGME certified. And so we work with our fellows for EMS. And so, well, you are a rock star, Nicole. And Elena, I think we need to show the folks where the exam is. Nicole, can you go forward with your slides?
Yes.
And
so,
Elena, can you point that out, please?
Here's our 68th session quiz information, and it is due September 14th at 6:59 p.m. Central Standard Time. And it will also be posted online and on Instagram.
So we want to thank you all for coming tonight. This is terrific. We had 250 folks sitting on the edges of their chairs, Nicole, listening to you. Just a terrific talk. So thank you so much for taking the time, 2 hours of your time after a long day. So please go hug your hub and hug your baby. And So folks, this wraps up yet another virtual shadowing session. This is the admissions committee season, so we're all staying tuned to see how the admissions committee are listening to these hours, but so far so good. And so we'll be back here next week, and we've got September planned and October planned. So if you keep coming back, we're going to be here. Nicole Plenty, thank you so much for your time tonight. What a rock star
Thank you guys for having me. I really appreciate it. And if anybody needs anything, please feel free to reach out.
Thank you, Nicole.
Thanks.
So anyway, folks, this will wrap up this session. We want to thank you for coming. And on behalf of the whole virtual shadowing team and Dr. Plenty, we want to wish you a good evening and